Good afternoon. I would like to thank SAGES for the opportunity to discuss bleeding after gastric bypass, location within the session of how to manage patients who are too unstable for transfer. These are my disclosures, none of which are relevant to today's presentation. Bleeding after gastric bypass is a common problem that may require management from non-bariatric surgeons depending on a patient's clinical condition and presentation. Today, we will discuss the incidence, etiology, diagnosis, and management of this problem with a specific focus on how location guides the above. So why is this important? With regard to bariatric surgery, we all tend to think of things occurring within centers of excellence. Where I practice in Northern Illinois, I work within a state that has 180 hospitals and nearly 30 centers of excellence for bariatric surgery. In the city of Chicago, there are 6 centers of excellence with additional ones in the surrounding suburbs, but set against a backdrop of over 100 hospitals in the greater Chicago area. This speaks to the regionalization of care that occurs within bariatric surgery in this area, and it also suggests that patients who undergo these operations may present for management of complications that occur in a hospital where they did not have surgery. This means that hospitals and surgeons need to be equipped to take care of patients who may present to a different hospital, who may require surgery at a hospital where they did not have their original operation, and where circumstances may prevent transfer to the original hospital where they had surgery. Bleeding after gastric bypass is a relatively common problem when you consider the number of operations performed in the United States. As many as 1 in 25 patients who undergo gastric bypass surgery will have bleeding complications afterwards. The incidence depends a bit on the definition and depends on how often labs are checked after the operation. Most bleeding events will resolve without intervention. Resolution and management of this complication depends very much on the location and where it occurs. It is also important to consider patients that present with an early bleeding complication, as well as those who present with a late bleeding complication. Most patients who present with late bleeding complications, defined as greater than 30 days after their index operation, will usually present with a marginal gastrojejunal anastomotic ulcer. For the purposes of this talk today, we are going to focus primarily on early presentation of bleeding. Risk factors for bleeding after gastric bypass include patient factors, pharmacologic factors, and surgeon's technical factors in how the operation is performed. We all know that preoperative DVT prophylaxis will reduce the risk and incidence of perioperative venous thromboembolism. And this does slightly increase the risk of bleeding with the surgery. However, there is no difference in bleeding rates with the use of heparin versus low molecular weight heparin for this operation. Much is written about 2 surgeon factors, anastomotic technique and staple line reinforcement usage. There are several retrospective series demonstrating a benefit or lack of benefit for staple line reinforcement with this operation. In addition, many retrospective papers are available with regard to weight loss, stricture formation, and bleeding using hand-sewn, circular stapled, and linear stapled technique for gastric bypass. However, none of these show a consistent benefit of one technique versus another. There are no prospective randomized series that demonstrate a higher or lower likelihood of bleeding with any of the techniques. Surgeons should approach these operations in the technical fashion they feel most comfortable with. Another question that has come up frequently, particularly with the use of opioid avoidance after gastric bypass surgery, is whether or not ketorolac increases the risk of bleeding. No prospective data have demonstrated that this is the case. It may be due to a low overall incidence of bleeding where there is not significant enough power to determine if ketorolac affects this. Bleeding after a gastric bypass follows this rule that presentation predicts the location and the management depends on the location. Patients who present with hematemesis typically have bleeding from either the gastric jejunostomy or another staple line within the gastric pouch. Patients who present with melena or hematochezia typically have bleeding from the jejuno-jejunostomy, from within the gastric remnant, or another portion of the biliopancreatic limb, such as the duodenum. Lastly, the third category of patients are those who present with postoperative anemia without obvious signs of GI tract bleeding. In bariatric surgery, minimally invasive surgery, and endoscopic surgery, we tend to focus on complications that occur within the GI tract. However, it is important to remember that bleeding can occur within the abdomen, within the abdominal wall, and it may not occur with presentation as a true GI bleed. This is a paper from nearly 20 years ago suggesting an algorithm for how to manage these patients and complications. Unfortunately, it relies on several things, such as daily labs, placement of postoperative drains, things like that, that we do not typically perform after bariatric surgery. Instead, a location-driven approach should lead to success in managing this complication. Bleeding from the gastrojejunal anastomosis occurs frequently due to the presence of the intact left gastric artery. Different from a gastric resection for malignancy, where a lymphadenectomy is performed along the left gastric is left intact. This leads to great perfusion of the anastomosis. However, it may increase the risk of bleeding, and this is present in all gastric bypass operations. In addition, some of the short gastric vessels may run on the posterior wall of the gastric pouch, particularly if a portion of the fundus is left within the pouch. Bleeds after a bypass occurring at this site can occur and be noted intraoperatively with the use of intraoperative endoscopy. It can present in the PACU or recovery room immediately post-op, or they can present 24 or 48 hours after surgery. Typically, these patients present with hematemesis, including clot that suggests an anastomotic bleed. Intraoperatively, since most surgeons likely utilize intraoperative endoscopy, this problem can be managed at the time of surgery. However, when it's diagnosed postoperatively, the management remains the same. Bleeding from the gastrojejjunostomy is managed with an urgent upper endoscopic intervention. There are a few considerations that are worth noting for this, which may depend locally on a specific hospital, operating room, GI suite, and anesthesia availability. Because this is a GI bleed, these patients should undergo general anesthesia that protects their airway, as it is an upper GI bleed. If this occurs in the PACU, it is likely most expedient to simply take the patient back to the operating room. If this occurs 24 hours or 48 hours post-op, it may be managed in the endoscopy suite. However, taking the patient to the operating room for an endoscopy keeps other options available should endoscopic intervention fail. Meaning, if a patient requires a trip to the operating room, they are already physically there, which reduces the need for transfers. Considering hemodynamic stability is also important, as well as the availability of blood after surgery. If the patient is returning to their same hospital where they underwent their bypass operation, they may not have a type-in screen for blood typing, since most surgeons do not perform this preoperatively. Special equipment needed would include an overtube for clot evacuation in the event of a large clot burden, endoscopic clips, endoscopic thermal devices, and depending on local expertise and skill, perhaps an endoscopic suturing device to manage the bleeding. These are images from select published case series demonstrating management of marginal ulcers and acute post-op bleeds that occurred in the early post-operative period. There's a very high rate of successful management from endoscopy alone, and usually is accomplished with a single procedure. If endoscopic intervention fails, repeat endoscopy may be performed. However, re-exploration may be required. Staple lines can be oversewn surgically, and in the event that endoscopic intervention is not successful, it is worth inspecting for other potential sources of bleeding. At the time of surgery, endoscopic evaluation can guide the surgeon to help identify bleeding along either the anterior or posterior wall of the gastrojejunal anastomosis. Bleeding can also occur after a bypass operation at the Jejuno-jejunostomy. This may present as melena or hematochezia, and it may also present as a small bowel obstruction from a large amount of clot burden. Endoscopic evaluation and management of this problem will again depend on local expertise and availability. Because roux limb length is usually at least 100 and maybe up to 150 centimeters, this may not be reachable with a standard adult endoscope. Alternatives include the use of a pediatric colonoscope, as well as double balloon endoscopy, which may require specific local expertise. If this cannot be managed endoscopically, the next step is by surgical intervention evaluation. The first step in surgery is to clearly identify the source of bleeding, since there are several staple lines that may be implicated. If an obstruction is present, the clot will likely need to be evacuated. In the image shown to the right from a published case of this, the clot extended all the way into the remnant stomach, shown at the top right of the screen. This may be best managed with a gastrotomy into the remnant to evacuate the clot. If the clot is only within the small bowel, then an enterotomy may be performed to evacuate this, followed by closure. Management of the actual bleed requires direct inspection in some cases. Some may elect to oversew the staple lines at all aspects of the anastomosis. For cases that are refractory, this may require takedown and redo of the anastomosis where and when appropriate. The next category of bleeding can occur from the gastric remnant or the duodenum. This may present in a similar manner to a jejuno-jejunostomy bleed with melena, hematochezia, or obstruction. Bleeding in the remnant can occur from the staple line where the gastric transection is performed, or it may be due to intrinsic pathology found within either the stomach or the duodenum. Since most patients undergoing gastric bypass typically do not undergo a routine preoperative endoscopy, a patient may have intrinsic pathology such as an ulcer or mucosal lesion that leads to bleeding. Diagnosis of bleeds at this area can be very challenging. Doing so using a bleeding scan is feasible. However, there is a high false negative rate of this. CT can be useful if it shows a large amount of clot in the stomach or an obstruction similar to the jejuno-jejunostomy bleed shown earlier. Management of bleeding within the remnant can be very challenging. Again, double balloon enteroscopy can be performed depending on local availability and expertise. Laparoscopic assisted transgastric endoscopy may be a better approach if the bleeding is truly localized to the stomach. In addition, a gastrotomy can be performed to inspect, evacuate clot, and manage the problem. And this usually can be handled with oversewing of appropriate staple lines. Other pathology, such as a duodenal ulcer, may require different intervention. Finally, bleeding problems that occur outside the GI tract should remain very high on the list of diagnostic considerations. These typically do not have a location other than intraperitoneal and within the abdominal wall. It's important to note that as many as 50% of post-gastric bypass bleeding conditions can occur along these areas. These patients will not have typical symptoms of a GI bleed, and the index of suspicion must remain high to make an appropriate diagnosis. Bleeding can occur within the omentum or the mesentery of the small bowel where transection occurs, can occur from injuries to the spleen or the liver capsules. In addition, short gastric vessels at risk for injury during pouch transection should be considered. And lastly, port sites and abdominal wall bleeds could be the source of the problem. Management of these typically is accomplished with supportive care and transfusion as needed. If this does not resolve on its own, re-exploration is the next step. These conditions can be corrected in any typical manner for postoperative bleeding. It is critical to remember that just because a patient has a gastric bypass operation, their bleeding condition may not be unique to those undergoing gastric bypass. It may be simply post-surgical bleeding that would be managed in the same manner as any other non-bariatric operation. In conclusion, bleeding may occur at several areas after a gastric bypass. Diagnosis of these requires an index of suspicion that should be based on the clinical signs and symptoms that dictate the location of the bleeding. Management of each of these locations should be guided by their location. Patients who are unstable for transfer due to a bleed after gastric bypass operation should undergo surgical and endoscopic evaluation and correction where and when appropriate at any hospital where they present. Thank you.